Just a little snapshot of my soul for you, that's all.
And we're all set position.
Me out eventually. It's one of the indicators.
All right, we'll come back to some semblance of order and start with a hearing from Executive Director Runyon about okay,
That's mailing age financial update.
financial update, and that's going to go into legislative update, and that'll feed into the strategic plan update. I think I would like you to just kind of roll with it, and then at the end, if anybody has questions, that sound okay? Great.
That's fantastic. What do we have?
Okay. Executive Director Runyon, and thank you for the enthusiasm, Board Member Beeman, about all of these combined updates. I think you have attached the March and April 2025 budget reports, and I'll just focus on the highlights from the April 2025 budget report. So just note, this is a snapshot of the biennium to date through April 2025. It doesn't include projections for the remainder of the biennium. Let's focus on revenue first. Revenue is 14.2% under budget, but total expenditures are 19.1% under budget. And this includes personnel services and supplies, and special payments. The cash balance represents 5.8 months of operating expenses. And generally our goal is about 6 months of operating expenses. And of note, through the end of the biennium, the projected cash balance represents 11.04 months of operating expenses. And of note, for the budget presentation, the end of the 25 through 27 biennium with all of the policy option packages included, legislatively approved the budget, which of course, as mentioned yesterday, still has to be signed by the governor to be implemented, would leave us with a balance of around 6 months of operating budget, and that includes the software upgrade that we discussed yesterday. Move next to the legislative updates. Since we provide a comprehensive overview of bills the agency is tracking as a complement to the weekly executive director reports, I wanted to focus on 3 primary bills we've carried or been involved with this session. We'll start with House Bill 3045. And that's our HPSP bill. It was most recently sent to the full floor with a due pass recommendation on 5/2025. I believe readings in each chamber have not been scheduled at the time of the most recent report, but that'll surely occur in the next couple of weeks. And I just want to let you know, on the second day of my appointment as executive director, I had to make a very pivotal decision on this bill. And I spoke directly with a senator who made it known that he was opposed and would advocate for killing the bill if we didn't make certain amendments. After looking at the amendments, to me, there was no difference between incorporating the amendments and killing the bill outright, as they strip the bill of its essential purpose. I was then asked by the governor's office what I wanted to do, and in consultation with some staff, I chose to refuse further amendments. I went down to Salem the next day and recorded a very inspired public comment, if you will, which I highly recommend you either read or listen to. And regardless of your feelings about the bill itself, I'm proud to have received the support of the Healthcare Committee, and I'm excited about the bill's current chance of passing. Thank you.
We have needed this for years. This is what other healthcare boards have the ability to do to help with the safety of organ patients, and that we have not had it to date is ridiculous. thank you for being passionate and sticking up and making sure that what we need is equivalent to what other healthcare boards are already doing.
Thank you, President Chen. We'll next move to House Bill 5028, or our budget bill. We became perhaps a little more familiar with yesterday. And let me start out by saying that I respect everyone's vote yesterday. I think it takes a lot of courage to stand up for what you think is right, especially when it's not easy. And I want you to know that that did not go unnoticed. Additionally, I also appreciated your considerations and the chance to, again, contextualize the importance of this bill. And regardless of where you stand, let's stand together in recognizing what a monumental success it is that we were able to get it passed. Back in February, while serving as pharmacist consultant, I was asked by interim executive director Rosa Klein and our former chief financial and administrative officer to accompany them to present our governor-approved budget to the committee. And we were told multiple times that this didn't have a snowball's chance in the summer heat of passing. And again, it represents a monumental success that we were able to get it passed. For me, this involved hours upon hours of presentation revision, preparation and delivery, several trips down to Salem, public testimony, talking to interested parties out in the community about this bill, and so on. And I could not have done any of that without the significant support I received from staff, in particular staff member Melvin and compliance director Efremoff, also compliant licensing manager Hennigan. And from there, we'll move to Senate Bill 236. So this was passed out of the Joint Addiction and Community Safety Response Committee, and where it passed unanimously in the Senate afterward, and now resides in the House for its final readings. And the SB 236-2 amendment contains the language from our House Bill 3046 and represents an extensive collaboration between the Board of Pharmacy and OSPA. There were many calls, Teams meetings, work groups, small groups, and chats that it took to get this ironed out in working condition. As such, I'd like to extend a special thanks to OSPA, specifically Brian Mayo, Amanda Meeker, Nikki Turzieff, or Nikki T in the event that I just butchered that last name, and to Board Counsel Hunt for their dedication to this work. As many of you know, this is the ghost of 2024 House Bill 4002, as I call it, originally constructed to allow pharmacists to prescribe early refills for medications for opioid use disorder, MRUDs. The unique difference between House Bill 4002 and SB 236 is that there will be less restrictions to pharmacists prescribing because the language about early refills has been stricken. Instead, prescribing will be dictated by a protocol designed by PFAC in consultation with a physician trained in addiction medicine. So stay tuned to the last couple of weeks of legislative session to see what happens here, but I'm excited about where it stands, its chances of passing, and the potential impact it could have in increasing access to these life-saving medications by allowing pharmacists to practice at the top of their education, training, and experience, especially in underserved and rural areas. That concludes that portion of the legislative update. Again, the remainder of the bills that the agency's tracking can be found on the bill tracker. And we'll move lastly to a very high-level update on staff's progress in implementing the board's 24 through 29 strategic plan, and that was effective as of April 2024. We'll just go over some key actions. So from the strategic plan, one of the key actions is monitoring rules feedback. And as I go through the key actions, let's give a few examples of how staff is meeting those requirements and implementing those requirements in daily operations. So in terms of monitoring rules and feedback, staff collates, communicates, and utilizes comments provided outside of the rulemaking hearing process to inform future rule drafts and brings forth those to board review. For the past 2 years, board has utilized Gov Delivery to enhance transparency and communication in attempt to gain targeted feedback by those directly impacted by rule changes. Staff has also worked to increase the visibility of topics on the board website to provide transparency and access in hopes to elicit feedback from the public. Example of this could include the fillable forms that we have on the website for ease of communication. Communication of new regulations as of 1/2024 board CPE for Division 115, 120, and 125 was posted on the board website. And collectively, these programs have been accessed over 1,400 times. Move to the next key action. Implementing a process to routinely collect and analyze licensee data with support from partners and interested parties. As previously stated, staff currently have created several user-friendly feedback forms that are located on our website as a way to internally collate, review, and assess feedback to apply to future rule writing efforts. We've also streamlined systems related to rule language suggestions or comments provided outside of the rulemaking process. For a key action, drafting and adopting new rules. Staff brought forth the rules prioritization list to the February and April board meetings that the board has updated and approved. Staff will continue to work on drafting rules in alignment with this process and bring back to the discussion to the board at regular intervals to check in. Staff will also keep in mind, as outlined in the strategic plan, to ensure to approach rules at an appropriate pace for the board and the public to stay engaged and informed of these changes. The key action of assessing uptake and impact of pharmacy technology solutions through collection of baseline and trend data. The board has been working on this for several years and has implemented rules to prevent pharmacy lockers, kiosks, and remote dispensing site pharmacies. Staff will continue to stay informed and bring potential revisions to current rules and new potential technology solutions for safe practices forward to the board as directed in the rules prioritization list. The action of collaborating and responding to proposals that support board goals through innovation and technology that address safety and access. Through interested parties collaboration, as mentioned previously, staff has worked with Pharmacy Coalition, or OSPA, on Senate Bill 236. Key action of applying technology solutions to enhance accessibility to board information and resources, and specifically completing accessibility improvement for the board website. Myself and Compliance Director Efremoff met with OHA representatives on 4/24/25, including Brenna Intiman-Milligan from the OHA Health Equity Innovation and Implementation Team to discuss how the board has implemented or smart law. Staff member Richmond presented to the Oregon Disabilities Commission in May, focusing on the board's implementation and monitoring of compliance related to regulation concerning Oregon smart laws. Staff member Melvin performed assessment of accessibility and identifying what changes can be made to the board website to provide broader access. The staff is currently working to update complaint forms for ease of understanding and use. And submissions are looking into the options to provide additional languages where applicable. In April 2025, staff met with OHA to continue dialogue on LEP and interpreter regulations, compliance with regulations, and accessibility of website. And lastly, in terms of operations, staff has worked closely with the current board president to increase transparency on agenda processes and to ensure that board members requested are captured in a consistent and transparent manner. New processes to catalog policy discussion requests and rule prioritization reviews were implemented. Compliance Director Efremoff has been working, or I've been working diligently to assess the agency needs and staff roles and responsibilities to meet the governor and board expectations. Staff continue to work on updating the software utilized by the agency. Our current vendor will be operational until June 2027, and our hopes is to have new software in place that can support both licensing and compliance operations and increase usability, self-service transactions for the public. The agency is compliant with and continues to meet all of the set strategic initiatives by the governor, including submitting the strategic plan and information technology succession plan by the deadline in May. We recently submitted a strategic plan update as dictated by the governor. And staff is still currently working with Board Counsel Hunt on updating all applications for both licensees and registrants to ensure clear direction on communication and hopefully faster processing of license and registrations. And that concludes the strategic plan update. President Chen, I'll pass it back to you.
You, and thanks for the 3 updates. We're open for board discussion. If there are any questions to Executive Director Runyon about any of those 3 topics. Legislative, strategic. Board Member Hall,
mentioned that we're looking at the applications again. I remember we were talking about potentially trying to have different languages available. Was that part of that or no?
They want me to write something in another language. But I don't know. I was just looking at the streamline. So Christine, I've been working on the tech one and just kind of streamlining it and making it easier to understand, but I don't know if there was a.
It's staff member FMF. I don't believe at this time related to applications, but we were looking at the complaint form specifically and making sure that that was in multiple languages and reassessing our website to see where we could do those translation services. We're a little bit different than some other agencies.
Yes, staff member Melvin, also as part of our DEIB plan, I think is maybe what you were thinking of. Some of that is dependent on our budget passing, so because some of that requires funding. So you'll hear more from us. We're not ready to speak to it today, though.
this is Board Member Chin. Comment did bring up a question I had reading the NAPB state by state specific rules that they have changed. There are states who have been champions of the, remind me of the, there's a specific doctor who committed suicide during COVID because of the stresses of what's their name? I don't remember, but there are changes to application processes that don't include mental health questions. And there are, I think that we've talked about this in the past about how we're updating our applications.
Yes, staff member FMF. Many other health-related agencies had questions of that nature. We have removed those from our applications several years ago, so we didn't have to do that additional, but keeping that lens and mindset and how new questions are asked is definitely in the review process.
So something that NAPB might not be aware of is celebrating what Oregon has done for several years. And so if Executive Director Runyon wants to, just send a shout out to NAPB about where, there aren't many states who have done that work. And I can find that email written if you want, but you won't all get the same emails. But I think that's an important thing for us to be recognizable.
Board Member Kroger, are there questions on license renewal regarding mental health status? I'm trying to vaguely recall when I just renewed my own license.
Staff member FMF, we can take a look at that. I only have been part of the
Okay.
initial application, so I'm not as familiar, but I will be renewing my license shortly. Also, it will be.
Yeah, I think there might still be a question on the renewal
Okay.
that we may want to look at. And I think not necessarily removing that question, but also maybe rewording it, like, because I forget the name of the award as well, but I think it's just how it's approached, because we'd rather have honest answers than people fearing that by answering, they might have their license taken away or investigated. But I don't know. I renewed fast, but I think there might still be a question on the renewal application.
Staff member Hennigan is on the call and she had her hand up. Chrissy, did you want to speak to that?
Good morning, this is Staff Member Hennigan. Director Runyon and I actually have a meeting about this topic in just a few weeks as a result of that NABP article. And so we're going to be looking into some of that information and seeing where we fit.
So thank you. That was an important topic from my heart. So
Executive Director Runyon, I believe what we were speaking about is the Dr. Lorna Breen
Yeah.
Heroes Foundation.
yes. So if you're not familiar with that foundation, her husband did a presentation at one of the NAPB meetings. And it was extremely moving, what had happened in the course of COVID to his wife and what he's done to turn it around into a national foundation to really address mental health in healthcare workers, and the stigmatizing issues that occur when somebody self says, "Oh, I've got those." So anyway, it was very touching and very moving. And I think it's important for us as an agency to look at our application process and our relicensing status and decide if we want to be in line with the heroes. But if you go on NAP website, you can find that information too. Thank you. Any other discussion? Right, it's 9:57. We are ready to, we'll go back into executive session then.
Oh, we have Board Member Patel is next on the agenda.
I'm not,
Sorry.
I am sorry, Board Member Patel. Thank
Oh, and
you.
it's mailing J, not K.
Aileen J. Board Member Patel. So, Board Member Patel has 15 minutes to give us a really riveting NAPB annual meeting update.
Board Member Patel, if you could just say next slide when you're ready for me to progress, that'd be great. Thank you.
Alright, NAPB 121st annual meeting in Florida. That was amazing. And maybe I'm going to change my mind and I'm going to move to Florida in 2033. It was really good. Alright, next slide. So there was a C on regulating technology to support innovation in the protection of public health and the well-being of healthcare personnel. So the C's basically pointed out that artificial intelligence and digital technologies are transforming regulatory approaches. Rather than replacing regulators, artificial intelligence is helping to speed up the compliance triage, identify patterns of risk, and streamline the reporting to NPDB, which is National Practitioner Data Bank. So they just use of artificial intelligence is paired with the human in the loop oversight. The next slide. So FSMB, which is like Federation of State Medical Boards, NCSBN, which is the National Council of State Board of Nursing, and NABB are all working on solutions. So for example, the Federation of State Medical Boards use AI to flag high-risk cases, while National Council of State Board of Nursing, they have implemented strict AI governance tools like LLMS, which is like large language models. They're the type of the artificial intelligence they can generate, understand, and translate the human language. And the bots. So while doing that, like ensuring the transparency, accuracy, and the data security. A clear policy framework ensures artificial intelligence is used ethically and securely across regulatory bodies. And I think that's very important when we are going in the artificial intelligence era. Next slide. The one more topic they would talk about in the same CE is with practice models evolving rapidly, NABP Institute is designed to help boards to make informed and timely decisions. In 2024 and to 2026, NABP Presidential Initiative was the NABP Research and Innovative Institute. A major step forward is NABP Research and Innovation Institute. This initiative aims to help pharmacy boards bridge the knowledge gaps about the new tech and the innovative practice models. So early proposal under review include the artificial intelligence or AI avatars for patient counseling and then enhanced prescribing tech. That was pretty cool. The e-prescribing tab, I do remember there was one meeting and, like when I started the pharmacy technician career in 2007, like more than 50 to 60% prescription you have to type down with your hands and everything. But now we have like e-prescription, so you barely type down anything, which is like listen the errors and everything. But that the new prescribing technology, they were talking about that. Let's say if we get the e-prescription and, sometimes we read the direction, like take one tablet once a daily, then take one tablet twice a day. So there is an error, whether it's one or whether it's two. Or let's say there is a drug-drug interaction or something. So that e-prescription technology they send back that prescription to provider. And they tell like you have to correct it, you have to look before you send it to the pharmacy. So I think that was pretty cool because sometimes we waste so much time in clarifying the direction, the quantity and everything. So I think like that was pretty cool. The goal is to empower boards with the evidence-based insight of the confidently evaluate the new technology. Next slide. There was another C on Board of Pharmacy Action Decision Tree, a just approach to discipline. So about this one, and I attend like so many Just Culture C since I'm attending NIBP meetings. This one is pretty cool too. The decision tree was developed in response to recommendation from the task force on unprofessional conduct. It brings the framework of fairness and consistency to pharmacy disciplinary action. The model helps board determine if the quality-related event was caused by a bad intent, recklessness, at-risk behavior, or the human error. What's the unique is the incorporation of medicating and the aggravating factors, making it more equitable than the one-size-fits-all penalty approach. It also addresses the role of pharmacy permit holders, encouraging evaluation of their broader work environment rather than focus solely on the individual. And next. They have like two branches and they have pretty cool like decision tree too. I did not include in the presentation, but if anyone wants it, I can give you. It's like if I do it, like I couldn't fit in the slides. But then they have like two branches, the pharmacy personal evaluation and pharmacy permit holder evaluation. And basically they just say like how we look at it as a bad intent, but it's reckless conduct, at risk and human error. But they have all the big decision tree for the pharmacy personnel and for the permit holder evaluation as well. There were some emerging topics which was include the pharmacy interstate privilege, which I think we just talked a little bit before. This is a new license portability model, not a compact, but an operational pathway that builds on the strength of the existing system. If implemented, it allows pharmacists to be the clean license to practice in multiple states without a full re-licensures, provided that they meet certain conditions like passing the law exam and undergoing a background check and whatever the other state requirement we have. It supports the workforce flexibility while preserving the state regulatory authority. And they're saying like it doesn't mean like state cannot have, you can have your own criteria and everything, but this is just kind of like speed up the process. Like as I think board member Kroger mentioned, if we have the emergency disaster or something. We also talk about a little bit Pulse product verification system and the DSCSA. So with the rising counterfeit threats, Pulse added an essential verification layer to protect patient, and they're like pretty good on the NEBP annual magazines. You can read more information on that one too. The Pulse PVS system helps ensure the drug legitimacy under the DSCSA. And I also see now all we have like primary wholesaler, secondary wholesaler, and they also have the logo of NABP, we are just verified. So that's good to know. It uses the verification router service to confirm the serialized product identifiers, lot numbers, expiration dates with the manufacturers in the real time. This is a critical in preventing the counterfeit drugs from entering the supply chain, especially given the rising cases of the counterfeit or altered medications. The last one is all the resolutions. They have more in detail information on the NABP website as well. So we just talk about like drug lost in transit, care coordination, community health workers. All the resolution, I think we agree with all the, whatever the committee recommended. The except two resolution, as far as I believe, like it was like sort of tied. That one was, I think, payer and processor payment rates and the methodology impacting the patient safety. It was regarding the reimbursement. So I think that was a tie because some things like, it's a payers, it's a reimbursement issue, other things like, hey, because that one is indirectly impacting the patient safety. Other tie was implementation of standard of care regulatory models. So I also talked to other state board members, and I feel like that was tied because I think there was some misunderstanding, there's miscommunication, but I think NABP is going to talk more about, or maybe they're going to form the task force or committee for the standard of care regulatory models. Last slide. Thank you so much for listening. And I do have download all the information if any of the board members, if they want the CE information, or if you guys have any question, happy to help.
Thank you. That was great. I really miss not being able to go. I love those meetings. The pulse, I've wondered if I can't remember, there weren't a large number of states who are participating yet in pulse. I don't know what the cost to the state board is to be involved in pulse, but it seems like I don't know if you all are familiar with that, but it seems like a really helpful tool for organ pharmacy. And so, but I don't know what the cost is of that to use it and anything involved in it. But everything that I've read about it is, why aren't we doing it? So I don't know if that's a topic that we need to put on the later on in the agenda. And then regarding interstate privilege, you said it's not the same as a compact. And I'm intrigued because I'm familiar with the time with the nursing compact. On our board, we were concerned primarily with what the cost would be to our agency when we're not getting over 100,000 licensees, getting licenses in the state. So I think that looking at interstate privilege, how does that affect how many licensees who pay for their license in our state? Because that's the only way we have income. So that would be something that I would be interested to just think through sometime, not at a board meeting necessarily, but just a thought in ahead about what that could mean financially to our organization. But I think I do agree with trying to figure out portability and being able to more easily flex in and out of states, but we have to figure out the financial impact in trying to do what seems like what makes sense. Any other comments?
Board Member Joyce. So Board Member Patel, could you expand a little bit on what you saw there as far as supporting tech-driven regulation and the use of AI? Has anyone started using AI already in pharmacy?
No, I don't know. I mean, see, there's artificial intelligence and then there is machines, right? Like automatic machines, right? So it's like sometimes they'll just combine together. If you just talk about just the AI, artificial intelligence, I don't know if you consider this example as artificial intelligence, but I just heard a little bit about all the health plan and kind of what PBM, they use the prior authorization kind of process. It's all like, I think it's AI driven, right? Sometimes they just say like, okay, this is just reject. This one is like, it's just because it's learned through the repetitive human interaction. So that's the one example I can think of. In the pharmacy, all the automation, like, like Walgreens has really good, robust automation. I think in one of your state last time we go. The central bill, yeah. So it's like that is automation, but I would not consider that one as the AI.
Yeah,
But it was so cool.
that's really interesting. Because, right now there's technicians and pharmacists that are employed in like prior authorization. They review
Yeah.
Manually, physically, look at, the formulary and the tried and failed list and so forth.
So why not miss that?
So, yeah. So, I mean, I'm sure there's some fear of, job loss. But also, with AI, if used appropriately, can definitely improve patient safety. Also, I'm picturing, because you put on here AI-powered avatars to support patient counseling. If I could see like a prescription locker with a AI pharmacist saying, take this with food, all that.
So there was one of the CE, it was a keynote speaker, I think. I forgot that doctor name, but he was literally, it was his avatar.
Yeah.
And he was like seeing the patients and he was kind of like giving that presentation. So to be honest with you, like I am personally, if you ask my opinion, that I would not be surprised that that will happen in our lifetime, that, the counseling done by real avatar, or like, yeah, or you don't have to see your doctors in person in the clinic, but because like there are so many sense that we was talking about like vitals, right? Like when you go to in-person
Right.
doctor's office, they are going to take your vitals, like your blood pressure, your oxygen. But this is like we have so much technology that you can even do your vitals through the technology and it will transfer to the doctor's office and
They're doing that now.
yeah.
Yeah.
So it's like basically you don't need, in-person visit.
We need to figure out being able to hear lung sounds better, but yeah.
Yeah, I mean, you'd be following an algorithm, whether it's gonna be an AI or human following algorithms. So anyways.
That was great.
Thank you. You have.
Yeah, board member Kroger, I was just to say, I think AI has been used in pharmacy for decades, actually. Whether it's DUR generators, whether it's reviewing and aggregating data around quality events. So it's actually, the word AI to me is a little bit more of like a hot topic buzzword, but this type of technology is really, really common practice. And I think what you said about, job loss or the fear, robots are coming for our jobs. I think in all of the keynote speakers and presentations that I've participated in around AI type technology, it's more as this, like, it's not ever going to take away the person. It's going to support and help the clinician, the pharmacist, the technician, but it isn't necessarily going to replace them. And I think that's a fear, and I think that's a legitimate fear is, do we want robots or AI providing consultations? What does that actually look like in practice? But AI has been used to support the practice of pharmacy for a long, long time and improve safety. So I think really great comments, board member Joyce. And it's just, to me, it's like AI is already here. It's just how is it going to get better and how, what aspects, what corners of pharmacy we're going to end up really, really utilizing it in.
This is board member Chen, just reflecting on what you had said, board member Kroger. One of the things that I think about is joy and satisfaction that, I know that there's a lot of stressors in pharmacy. But that face-to-face interaction that a pharmacist has with their clients and that counseling and getting to know them and their families, when that gets replaced by avatar and the pharmacist is doing just not doing that interaction, are the pharmacists gonna miss not having that interaction and that knowledge about those people?
Board member Kroger, I don't really think that's where it's going. I think this technology, in my opinion, this is just my thoughts on this. This technology is I think being used to free up pharmacists so that they can spend more face-to-face time providing those services.
That's
The
what it-
avatar bit was kind of, I'm trying to think of that presentation. It was really interesting and sometimes it's, you know, you hear more of those situations in maybe doctors' offices type place. And even in the visits I've been in recently, they're like, hey, do you mind if I have my phone here? Because I'm going to be using AI to generate my chart notes.
No, yeah.
I personally don't feel like we're going to be replaced by avatars when it comes to consultation. I don't think that. I mean, I'm not
But
betting
you
on it, though.
understand my concern
Yeah.
for you, pharmacist, is that I would not want to not have that interaction. Okay, thank
Board
you.
member
Okay.
And it's in my experience that most patients in retail, they don't want a consultation anymore. You hear more denials on consultations than and patients wanting to have that conversation regarding the prescriptions.
But you are absolutely right. More they're getting their self-educating, and the newer generation I have, seen that they don't want that more human interaction. They are like, better they talk with them. I want my own people back.
Just text it to me.
Right, that's true.
And this is Board Member Beam, I think a lot of that has already been taken away, at least in my experience with pharmacy closures, with the increase in workflow, with differences in workflow, with COVID, with having to talk through plastic while you're double masked and you're in your 14th hour of being hypoxic. And you're,
Tell us how you feel about that.
I mean, no, in my own experience, I think a lot of that, I think finding that connection and finding that, I mean, I know it still happens on a daily basis, but I think that rough patch the pharmacy has kind of gone through has diminished that a bit already. And so I do think it's still going to be there because there's still the conversations that have to be had face to face with, human to human. And I do think though that AI in whatever capacity, even if it is in a counseling capacity or whatnot, it's just going to be another option for patients that need a different type of service. But when you have those weird questions or I don't know what's going on, these weird side effects, you're still going to have that.
We're gonna put it all on YouTube. Thank you. Any other comments or questions for Board Member Patel?
Not for Board Member Patel, I was just gonna chime in and say, we use this and it's not a robot, but a non-human provider.
Okay, well,
We
Japan
had an encounter with a non-human provider.
Japan has robot nurses. I don't know if you've ever seen that, but there is technology to do patient care with the robot. Yeah. Anyway, so thank you, Board Member Patel. That was very intriguing and very helpful. All right.
Representing.
Yes. Indeed. Okay, so the time is now 10:19 a.m. Where we ask Mr. Rob to exit because we're gonna go into executive session, good sir. You have a great lunchtime. You have a long time to take a good walk. You're not coming back? You're not coming back? It's good to see you today. Thanks for being here. Safe travel, sir. This executive session is held pursuant to ORS 192.660, para 1, 2, little f, capital L, ORS 192.690, para 1, ORS 676.165, and ORS 676.175, which allows the board to meet in executive session to consider information or records that are exempt from law from public inspection. Representatives of the media and designated staff shall be allowed to attend the executive session. Representatives of the media are specifically directed not to report on any of the deliberations during the executive session, except to state the general subject of the session as previously announced. No decision may be made in executive session. At the end of executive session, we will return to open session and welcome public back into the meeting. So is there a motion to move to enter executive session for the purpose of legal advice, review, and discussion of investigations and disciplinary cases at 10:21 a.m.
So move, Board Member Beeman.
And Board Member Joyce?
Thank you. Board Member Chin, yes. Board Member Joyce?
Yes.
Board Member Beeman?
Yes.
Board Member Hall? Yes. Board Member Cuthbert? Yes. Board Member Kroger?
Yes.
Board Member Patel?
Yes.
Board Member Pineda?
Yes.
Motion passes. And we'll wait till staff transitions from open to executive session.
You flip the door.